My topic today is going to be more on AI in healthcare. And I'm going to be discussing kind of new novel applications, the future of AI in health, and exploring it from maybe a personal perspective, but also kind of a narrative perspective, and then exploring kind of things that might seem a little bit chaotic or a little bit excessive in terms of maybe possible uses, but I think it'll be good. First thing, so just a little bit about me. So my name is Dr. Zaahir Moloo. I am a family physician in Edmonton here. I got my MD at the UFA, and I am also a co-founder of Scribeberry. And Scribeberry is essentially an AI medical scribe. We automate a lot of clinical documentation, a lot of clinical notes. We've built out kind of a whole platform of different AI tools to make healthcare professionals' lives easier. And so with kind of that in mind, I wanted to kind of set the stage a little bit personally too about me too, because that kind of ties into where I see healthcare going. So a bit personally, I grew up in Edmonton most of my life, but my parents were immigrants. So came to Edmonton at a young age, about 8 years old. And the reason I bring this up is just to kind of share their story and how that relates on kind of the innovation and entrepreneurship angle of things. So watching them kind of come to a new country, navigate different barriers, barriers in healthcare, for example, different challenges, different circumstances, it kind of instilled in me a little bit of, lack of fear of failure or kind of a drive. It's okay to fail. It's okay to innovate in a way that maybe is a bit more risk-taking. And so I wanted to kind of share that just because it'll kind of frame, when I talk about crazy applications in healthcare, the hope is you don't see me as some kind of odd person who's saying these weird things, but that you just have that little bit of context about why maybe I'm making claims that perhaps are a little bit far-fetched. So I guess to start off with, every one of us has kind of an introduction to technology. And for me, maybe I'm dating myself a bit, but for me, my canon event when I was introduced to technology was Google. For some others, it might be something else. For younger kids, it might be like their first iPhone. I don't know. But I remember very clearly when I was a young kid in Dubai. I was probably 6 or 7 years old. And at that time, I was with my sister and my brother. They were sitting in a room, called me over to this big computer, that probably runs so slow that if anyone today used it, they would smash the screen instantly. And she showed me Google. And I don't think this was the exact screen I saw. It was probably a bit of a newer version. This is kind of the original Google search engine here. So typed in, a query, and instantly, or at that time, what seemed like instantly, a result was there, right? That was my introduction to tech. And I still remember that moment to this day because it was so impactful. It was so profound. Why am I sharing this? How does it relate to healthcare? I'll get there. But just to kind of keep this in mind, right? Drawing parallels to this with this kind of beginning of a new age. And from there, where did we get to, right? So the internet as we know it today, we went from Google to dial-up internet to broadband to an explosion, right? I mean, obviously, we've lived through this. The web is ubiquitous in our life, right? You can't go anywhere without being connected. There's Wi-Fi everywhere. The internet has become an integral part of our life, right? Computing speed has scaled. And again, right, this was an exponential growth. And if you look at the way we live today, this is just a part of life, right? Like we don't think about logging on to the internet. It just exists, right? We have our phone with us at all times. So how does this kind of tie into AI? And I'll talk about this first. So the relation to AI, and then go more specifically into healthcare. Obviously, being an AI conference, as many of you are familiar with kind of Moore's Law, AI is growing at an exponential basis, right? When ChatGPT kind of first came out, to me, that was the canon event for AI. One that kind of brought it that little bit of more exposure on a global scale. But whatever metric you look at, whether it's kind of the length of tasks that we can do with AI, whether it's more, looking at benchmarks of different models, the growth is exponential. And so here's an example, I just wanted to kind of point out. So if you look at the GPQA Diamond benchmark, and you compare it to a human PhD who's using Google, again, tying it back to that, we've surpassed that, right? We're at the point now where O3, ChatGPT, or GPT's latest model, will answer those questions with more accuracy than a PhD level candidate using Google. And so it's phenomenal, like how in a short period of time, we've gotten to such a place where these things are so prevalent and so powerful. But I guess, if you zoom out, where are we actually? And this is kind of relevant to healthcare. So this is not scientific at all. I just pulled this image on Google. But it's just to kind of give you an idea. If AI is kind of on this exponential growth curve, where are we? Are we kind of at the bottom there? Have we started to climb that more exponential phase? At least my perspective from being in healthcare is that we're still at the bottom, right? We still haven't scratched the surface of kind of what's possible or what's plausible. And even in the AI field itself, AI is not ubiquitous, right? Most people, let's say outside of this room, use maybe ChatGPT for recipes or to answer questions, but nobody really lives and breathes it like automatically every day like we do the internet. And so I think we're in that early adoption kind of infancy stage of AI in general. But yeah, it's kind of boring, right? I'm probably saying a lot of stuff people already know. So how does this kind of relate to healthcare? And so this is kind of where, we switch focus a bit and we talk through kind of where we are exactly when it comes to healthcare. Today's applications, some of you might be familiar with them, some of you maybe not, and they seem really impressive, right? And I'm saying this as someone who has kind of an AI product, an AI company, a startup. Are AI scribes in healthcare more like dial-up internet, right? Like the early adoption stage. What we're seeing now with agents, is this kind of that next step? But are we still in that early infancy stage? And that's kind of where I think we are, or I want to convince you we are. So before I go forward, just kind of a note on regulation and kind of acceleration in healthcare specifically. So with a lot of novel tech, especially in healthcare, regulation obviously is important and serves a role. To me, there's kind of two aspects to regulation. One is regulation that is impactful, essential. It needs to be there to prevent harm. And then we kind of tip over into unhelpful regulation that maybe is a little bit more bureaucratically inclined or tends to slow innovation. I think regulation has a role, and I'll go through kind of barriers and how we can maybe overcome that or collaborate with organizations to do that. But I'm going to focus more on this accelerationism piece, just to kind of show you what maybe is possible, what's maybe in the pipeline. So yeah, where we are now. So this slide here, this is from Elion. So Elion is kind of a database. You can go online, look it up. It shows you all the AI tools, or most of them, that are publicly available right now that are being used. So if you look on the screen there, you can see ambient scribes, of course. And so that's where a clinician and patient can talk to, and the note is structured at the end. And they don't need to kind of, type or chart or do any work. In this, the clinical decision support. So things like, for example, a co-pilot, that maybe is helping with diagnostic suggestions for clinicians. There's a lot there. One that always comes up, and it always came up even when I was in medical school, is AI imaging, right? And I'll get to that later with specific examples, but AI imaging, radiologists, will they lose their jobs? I don't think so, but we're going to see a lot of development in that area for sure. And then, yeah, more kind of patient-facing or administrative support, right? So that's kind of the state of play right now in terms of what we see and where we are. But when we kind of think of where are we going to go from here, I think we should think of problems that need solving, right? Especially in healthcare. There is a ton of problems in healthcare. And I'm saying that in healthcare, but I'm sure as patients, everyone has experienced it, right? Whether it's wait times, whether it's care gaps. But one of the kind of first things that I want to focus on really is data interoperability. And so what is data interoperability? If you're not a clinician, this might be familiar or not familiar to you. And you might be thinking, why do I have grain silos on the slide? What's wrong? So data interoperability, essentially, the way healthcare data is structured right now is that it's in silos. You might experience this if you go to your family doctor and you ask them, what are your test results? They might not have access to it because maybe another doctor ordered those test results. If you go to the emergency room, maybe one time, and then you visit 2 weeks later, a different emergency room, they might not have access to those records, and so they're going to ask you all those same questions all over again every time. As a clinician, this is incredibly frustrating, and as a patient as well, I can't imagine, what some patients who have complex needs go through. It's frustrating. It's a huge problem, right? It probably results in increased costs, increased, test ordering, delay in care. There's probably many negative outcomes associated with this. But one of the first applications of AI that I wanted to talk about was data interoperability and how we can solve for this with AI tools, and how we can do this right now on a small scale, and how this is possible to solve on a larger scale, obviously pending all of the other regulatory and so on and so forth kind of barriers. But so I wanted to kind of bring it back here to agents. So what are agents? Probably, we've been talking about it for a few days now. Last year, was kind of more LLM focused. This year, maybe a bit more agent focused. But essentially, you give an LLM the ability to plan, you give it some memory, and you give it tools, right? With those tools, it can go and actually do things. And these things can be profoundly impactful from a data interoperability perspective. So I'm going to show you a tool here, and just kind of how it can be used, or not this tool specifically. So this is something that we've developed, but in this context, it's more geared towards the product. It's more geared towards kind of solving administrative workload and filling in charts. But I'm going to go through the concept behind this and how it can really relate to data interoperability. So what you should be able to see here is kind of a fake electronic medical record, or EMR. And on the right here, you see this little extension, right? Important to note here that this extension here has no direct API access to this health record field. A clinician comes in, they press one button here, right? Little magnet. I know the UI is kind of, we had to figure out a way to get the point across, but, and now, just kind of instantly drawn in there, you have all of this patient context, right? Again, it's all fictional. But what we did was, with a click, kind of pull all the data from that EMR. Now, what I have pulled open here is a completely separate EMR system, right? This is my clinic EMR. I'm using the staff section, not the patient section, because I don't want to dox any patients here, and it's a huge violation. But just to kind of show you the idea here, separate system, no API connection, no access, no, not talking to each other in any way. You come in here, you press a button, And now all those fields should hopefully fill out, right, on their own. The address, the phone number, the city, and it's all in there. It's all mapped to the right place without any prior mapping, without any kind of tool there. So yeah, to you guys, you might be like, what is this like small, insignificant tool, and why am I showing this? But how does this relate back to data interoperability, right? And so, yeah, do we even need an API anymore? Think of this, right? Right now, how is data stored in healthcare? You have private providers. You have your TELUS, your QHR, and you have patients. You go see your doctor. It gets stored in the record system. That's stored in the cloud or somewhere with one of these providers. And then those providers hold that data, right? And oftentimes in healthcare, it's hard to make them play ball or share that data with other providers. Why? Because there's a vested interest for them to keep that doctor or that customer there. And so this is a huge problem, right? The only perhaps way around this right now is if a government organization steps in and they're like, okay, you have to mandate, we mandate you have to share data across all these different vendors. In practice, there's a lot of politics at play there. There's lobbyists, there's money involved, and so that doesn't really happen, unfortunately. But imagine if we take the technology behind this, and if you, as a patient or as a doctor, you come to your EMR system, you click a button, and you say transfer data to new EMR, and in the back, the AI agent takes it from one system, takes all that data out, maps it to another one. That problem is gone, right? The bottleneck that's there for data no longer exists. And again, I'm bringing it back. This is a very optimistic and, at this point, probably not realistic point of view, but I just want to show you from a technologic point of view, we're there. We can do this. Yeah. So data interoperability, one of the big challenges. And so that was one kind of example that I wanted to bring up here. The next one here, so last year when my co-founder was here, we kind of showcased the AI Scribe. That's kind of last year now. It's not really as relevant, I would say. It's more prevalent, but it's not as novel. And so the second kind of tool I wanted to showcase here is sort of agents. So taking that AI Scribe and now applying it with agents to broaden that horizon a bit. And so I'll play this video and then actually have a really fun kind of demo, but play this here.
What are agents? Think of agents
can you guys hear the audio at all?
That will go out, talk to patients, and do your forms for you. That's right. It'll do the complete form for you.
Hello, I'm a digital health assistant, and I'm calling on behalf of your healthcare team to gather the medical information required for your Canada Revenue Agency's disability tax credit certificate.
CRA disability tax credit, no more. AISH form, no more. Insurance forms, no more. All the forms will show up done inside of your Scribeberry account. Here's how it works. Create an agent, provision one from the store, or create your own. Once you have your agent, it'll have a phone number. You can either get your patient to call this phone number, or you can give your patient a direct link to the agent. Alternatively, the agent can call your patient. Regardless of how this happens, once the conversation is done, the entire finished form will show up inside of your Scribeberry account. That's all.
So it's a promotional video, obviously, but the concept, and I want to demo this too, is that now you have, instead of scribes, you're going to have agents, right? So you're going to have tools and capabilities to take this to the next level. I'm going to talk about a lot of possible future applications and implications of this, but I wanted to kind of give you that idea. So this is my kind of fun demo here. So I actually set up an agent that's going to fill out a CRA disability tax credit form. Now, for those of you who are familiar with that form, as a physician, like that's like the bane of my existence. Like, patients come in, and we often have to do these like all the time. Like, and it's a huge time sink, right? 20, 30 minutes. You have to review the chart. You have to go through previous records. You have to fill this out. You want to do a good job, get your patient improved. In terms of just a bit of a demo here, I'm going to put on my headphones so I can hear this, but oops. So I made a medical Tupac agent here. And so if we look at the instructions that it has, it has this opening statement that's a little bit silly, and then it has instructions. And so what I'm going to demo here is I'm going to open this up. Hopefully the audio here is captured, and then close this.
You this be the medical two-pack, here to take a CRAE disability tax credit history. Don't be acting a fool or ill, bust a cap in your medical behind.
Hello, how's it going? Can you hear me?
Yo, I hear you loud and clear. Don't you fret. Just need your name first. Let's make it a duet. Gonna click.
My name is Zaahir. Yeah, why are you rapping at me?
Oh, I see you playing games, but don't you sweat. Your name is here. That's a vibe I won't forget. Now, let's dive into your health. Don't be shy. Tell me your symptoms. Let them fly high.
I have a headache. It's really bad. But if you keep talking to me, I'll get very sad.
A headache, you say? No, that sounds quite rough. But don't you worry, we'll get through this stuff. Rate that pain on a scale from 1 to 10. Let's figure it out so you can smile again.
Okay, I gotta go. But it was nice chatting with you.
Oh, don't run away. We're just getting started. Your health's the game, and I'm the one charted.
So, yeah, a little bit silly. But, I mean, talks are kind of boring sometimes, so I thought I'd kind of switch it up. So, just to kind of show you the application of this. So back kind of in Scribeberry, you get that PDF. This might be an old one here. So that PDF kind of populates, and now the agent, instead of it just being a scribe, it's kind of taking that conversation and filling out the form, right? And so in a practical sense, imagine this. If you're a physician or clinician, you have a patient panel. A patient comes to you. They're like, hey, I need this disability form filled out. Instead of you getting that form, filling out, you give them a QR code, you give them a phone number, they call, and that form shows up done for you, right? Yeah. So where am I getting with all of this, and why did I bring up that Google thing at the beginning too? Is in healthcare right now, we're really siloed off. We have all of these obscure tools, but I think where capability truly lies is to create a healthcare OS. What do I mean by this? I mean like an operating system that's congruent for patients, for clinicians, and at a system level functions in a way very similar to kind of what the internet functions like today, right? It's autonomous. You don't think about it. It just happens, and it's normal. And so that's kind of the optimistic vision I have when it comes to AI in healthcare. So if we take those two applications and let's say we add some more tools, right? So we had an agent that could fill out forms, and we had obviously kind of the data interoperability tool. And obviously I'm stretching that. You take that, expand it out. What are things that are possible, right? And I'm going to go through this from a clinician level, from a patient level, and then from a system-wide level. What is actually technologically possible? The first, we kind of went through a bit. Imagine all of this data comes in. You have this pre-visit data. You have unstructured data that comes in, and an agent or an AI can handle that and push it into various different systems on its own. There's no manual data entry. There's no barriers between the different providers. It just happens. A second tool, right? And this is not so big or serious, but no-show recoveries, right? Imagine a patient misses an appointment. We have an agent that can call. you apologize, reschedule, and that patient now is no longer lost to follow-up or lost, to somewhere. Insurance and prior auth, right? This is a huge nightmare, more so in a private health system, but also here. Filling out Alberta Blue Cross forms for drugs, for example, right? It's a huge hurdle. Imagine if we had an AI that could, again, extract data from different systems, take that, put it into a form, submit that form, follow up on that, and make sure that claim is approved. That's huge. And then, yeah, the form filler we kind of talked about. Referrals, right? As a clinician, so in Edmonton anyways, there are a lot of separate pathways to refer patients, right? There's the SCOPE program, there's the FAST program, there's Glenrose referrals, which take like eons to get done. And patients suffer, right? Like if you have a child who's neurodivergent and you try to refer him to the Glenrose, good luck, right? It's going to take forever. And half that battle from a doctor's perspective is filling out the form, right? Actually getting there and being able to transfer data from one thing to another. So imagine if you had this agent, again, that could take data, fill out this form, and submit it for you. That would be huge. And I actually think this is possible. A few more use cases there. The last one I just threw in as a joke, but maybe the agent can go to medical school and become a doctor too. Well, kind of a joke because, at this point, and I'll reference this later, a lot of the newer models are outperforming, doctors when it comes to clinical queries. So, continuity of care. This one kind of ties into public health, right? Imagine from a public health standpoint, you have an EMR full of data. You know what patients are diabetic. You know which patients haven't followed up. Right now, a lot of processes involve manually pulling that data, curating it, having to go through it, having to view it in a UI. But imagine if that just happened automatically. Like just in the back end, you have an agent that's just figuring out, hey, who needs an eye check for their diabetes? Who needs foot care? Who needs wound care? Who hasn't, been taking their meds? Who's at high risk of heart failure? And it just goes, contacts them, and books them in. So possible applications from a tech perspective today. How does this progress, right? So this is, again, from the clinician perspective, right? You're scaling agents to carry out tasks, and you're doing it without taking valuable time away from your patient care. And that's huge. Now, from the patient perspective, right? This is really interesting because imagine as a patient, right? You call a number, you reach your receptionist, right? Now you got to book an appointment to see the doctor. Then you got to see the doctor. You got to go to the pharmacy. You got to go to the lab. Everything is really broken up, distinct. Each one of those systems don't talk to each other. Imagine if you had one central point of contact that you could call that handles all of that. It gives you your appointment time. It faxes over the requisitions for you. It completes whatever forms you might need. That's kind of just preliminary what we saw with the agent there, with the form filling one. If there's any translation or language or understanding barriers, it bridges those gaps instantly, right? You don't have to wait for a translator. If you speak French or Punjabi or any other language, that just happens automatically, at the time you're talking. The agent just switches, and that bridge is, that gap is bridged. So let's see here. So this kind of more on a system scale. Right? Right now, as I was alluding to, you have all of these legacy EMRs, you have fax services, etc. They all require FHIR, HL7 adoption, and complex APIs to talk to each other. But imagine a world where that's not really relevant anymore, right? You have teams that coordinate referrals. They're monitoring wait lists. They're kind of prioritizing, based on acuity and closed care loops. A good kind of practical example of this is, taking that agent for example, and applying it to an emergency room setting. And this obviously is where the regulation comes in and FDA approval and so on. So from that point of view, maybe not yet, but from a technical point of view, you could have an agent in rural communities in an ER. When a patient walks in to an urgent care in ER, that patient is triaged, right? That AI agent can be trained to know all the risk scores, all stratification of all different conditions, and then assign that patient. How urgent is this patient? Where do they kind of fall? So, yeah. And so I won't kind of keep going through all of these, but the general idea is, we're bridging that gap between data, and I think that's really important. But yeah, in summary, you have kind of a healthcare OS with AI, and that's kind of that glue that can hold things together and pull things together that are very disjointed. So yeah, this is kind of boring, because it's all data, and data is not always interesting with AI. Maybe it is. To me, it is. But so I'm going to kind of talk about more medical applications now, and more things that are kind of coming down the pipeline. And I'm going to try and mix kind of realistic or possible, or actually, currently available applications with things that are maybe more adventurous, right? The first thing here, so Luminetics Core. Right now, in order to get, let's say you're a diabetic patient. Why is this a problem? Diabetic retinopathy, right? With diabetes, high rate of retinopathy, which essentially means, you have a high likelihood, in summary, of losing your eyesight or going blind. Diabetes is a very microvascularly, what's the right word? It affects all the small vessels in your body. And so, the smallest, most fragile vessels are in your eye. And so normally what happens is, because of the diabetes, because of how fragile those blood vessels are, you end up with retinopathy. The first kind of cool tool, so this is Luminetics Core. Essentially, imagine, you could go to your family doc or even a local health clinic that has a nurse in rural settings. And this is kind of a point-of-care device where you essentially look into a camera, and this software tells you, hey, does this patient have retinopathy or not? The difference here is you don't need complex, specific photos like you would, let's say, an ophthalmologist or optometrist. You just kind of have that done. Down here, so this kind of goes over how it works. If that diabetic retinopathy is detected, you can then tell one of the other agents. I made that edit, by the way, to an eye care professional, and so keep the theme of AI. This is another kind of cool tool here. So this is kind of taking the concept of AI scribes, which are obviously being used right now, and expanding it. When I first read this name, I thought this guy missed a great opportunity, marketing opportunity. Could have just called it AI Copilot, but then I looked it up. It was actually called Visionary. So this is a really cool tool. What it does is it's inputting data from your EMR or from a clinical source, and it's also inputting visual data. So whatever the ophthalmologist or optometrist is looking at, and it's using both with the patient conversation to actually generate results, next steps, and kind of close the gap. And the reason why this is really cool is oftentimes, in ophthalmology, when you have these different systems like PACS, which has the images, or your EMR, things get missed, right? An ophthalmology clinic that's going really fast, the doc's not always going to have time to maybe look up all these results beforehand. And so this is a really kind of cool application as well. Digital twins. So this is kind of one of those more crazy ideas, right? That has a lot of ethical and regulatory implications too. So imagine this, right? You have kind of a digital twin of a patient. For example, let's say you have a large language model or an AI system that can ingest large amounts of data about a patient, and from there, look at kind of different clinical factors and come up with, okay, based on an algorithm, what would be the best combination of drugs? Let's say if they have diabetes or cancer, or in cardiology, how might a certain patient respond to a certain pacing device depending on different factors, right? Depending on the physiology, depending on their echo, depending on whatever it might be. So this is kind of this experimental concept. Will it happen? I think so. Like I said, I draw it back to the exponential curve. From a tech perspective, I think it will. From an ethical and regulatory perspective, I'm not so sure. But yeah, this is really cool. So face to gene, for colleagues in pediatrics, for example, oftentimes diagnosing complex kind of neurodevelopmental disorders can be really challenging, or genetic disorders, I should say. And so what these guys built here, face to gene, essentially take a picture of that patient, and it's able to confidently identify which syndrome or what genetic disorder they have. Which is huge, right? Some things, maybe are a little bit easier to spot clinically, but other things require a trained eye. And so making this more accessible, let's say, for primary care, is a massive advantage. Surgery, robotics, yeah. I wanted to kind of include this too. This is a whole field on its own. Someone could give a talk on this. Maybe they are, but... So I'm not sure, is anyone familiar with STAR, or has anyone heard of this before? Okay, but essentially, right now, robots can, to an extent, perform surgeries. Maybe not complex surgeries that require a lot of complex decision-making, but if you give them an uncomplicated appendectomy, for example, this can be done by an AI robot under supervision, right? Again, regulatory and ethical implications, but just purely tech. How does this then kind of carry over? Because if you now add the ability to kind of detect patterns and detect signals, how can you leverage that in the same kind of field? So for example, if you install a prosthetic limb, can you use your mind to control that prosthetic? And so I wanted to kind of bring up the video here with Neuralink. And many of you maybe have seen this before, but I think it's an awesome watch. So I'm just going to hit play here.
In January, Elon Musk announced his company, Neuralink, had successfully implanted a chip in a human. That person is now sharing how his life has changed since. Will Reeve with the story.
I didn't have anything to wake up for in the morning, and this has changed that for me.
In a GMA broadcast exclusive, Noland Arbaugh, the first human implanted with a Neuralink chip in his brain, is telling his story.
I accepted that I was paralyzed and that was my life. I always held out hope that it would all get better.
At 22 years old, Noland says he dove headfirst in waist-deep water, struck something, and sustained a spinal cord injury. He couldn't move from the shoulders down.
From the time of your injury until earlier this year, what was your daily life like?
I mean, one thing about being paralyzed is that there's a lot of time to sit and think. So I thought through basically my whole life and realized all the mistakes I'd made and what I could do better.
Then, just last year, Noland, now 30, receiving a life-changing opportunity.
One day, one of my buddies from college called me up. We talked pretty regularly, and he was like, hey, Neuralink, they opened up the human trials. And I said, what's Neuralink?
Neuralink, co-founded by Elon Musk, is an experimental implantable brain-computer interface, or BCI, a chip surgically implanted by a robot and connected by threads to a patient's brain that allows the patient to control a computer or smartphone with their mind.
This is all from there to there.
Yeah, man.
Wow.
Neuralink is not the only company working on this technology. Several others are also testing their BCIs in paralyzed volunteers. Noland now joins that small group as Neuralink's first patient.
I was just very happy that I would be a part of something that I believe is so monumental in this next step forward of helping people with paralysis.
What can you do now with the chip implanted that you could not do prior?
I can control a computer just like anyone else can, which is not something I was able to do beforehand.
You just played some music?
Yeah, man.
That's awesome. Do you worry because you are the first patient that something unforeseen could go wrong now that this is inside your head?
I wouldn't say worry. It was something where I knew that if I did this, then it would take a lot of headache and heartache away from the people down the road.
Just last week, news that some of the threads in Nolan's brain had retracted, affecting the performance of the device.
How'd you take the news when they told you that the threads had retracted?
Yeah, it was really hard. It was very, very hard to give up all of the amazing things that I was able to do. I think I had cried basically afterwards.
The problem becoming an opportunity for the makers of Neuralink to explore solutions.
The reason we do clinical trial and early feasibility trial is to uncover these sort of issues as early as possible before they get marketed. And we rolled up our sleeves and found various different ways to for Nolan be able to recover his performance, which we have successfully been able to do.
As for Nolan, the future of the technology only looks bright.
It's going to be amazing when someone can have a spinal cord injury, go into a hospital, get surgery, and walk out a couple days later. I think it's going to happen. I don't think it's as far away as people might think.
I like his shirt at the end too. But yeah, it's remarkable, right? Like the optimism that he has for the future, and also kind of the hope that it gave someone. And so when we think of these applications, I think there's a real human element to it too. Obviously they referenced a bit of kind of the ethical implications of this too, right? Well, what if something goes wrong? How does that kind of shake out legally, ethically, from a human perspective? What does that look like? But I think it's phenomenal. And this kind of, when I first saw this, it blew my mind. Oops, I'm playing it again. This is just that trial that I wanted to kind of reference back. So this was the robot surgery, right? And back in 2022. So who knows where we are now. Another kind of cool use case here, patient monitoring and early intervention. So this has been rolled out in different settings, right? There are a few different trials on this right now. Whether it's for sepsis, CKD, or chronic kidney disease, emergency rooms, can you use AI to predict disease before it happens? And before it's even humanely visible to us? So a lot of these trials have kind of looked at this. One of the cool ones, and the ones that kind of struck me, was one that was done in a pediatric emergency room. And if you know anything about kids, is that when adults get sick in an emergency setting, we tend to kind of slowly kind of deteriorate, and you can tell the person's getting worse. With kids, it's kind of like they're good. Oh no, right? They're coding, or they're something is seriously wrong. And so in a pediatric setting, especially let's say in an urgent care setting, if you can look at slight alterations in a patient's vital signs and in a kid's vital signs before it becomes clinically apparent, maybe you're doing something else, maybe you're not noticing those small changes, whether it's vitals or labs, and use that to actually intervene early, you can save lives. And so previously, these Akron's children kind of relied on this old pediatric early warning score, and then they started using AI, and you had this reduction in response calls by nearly 40% in an acute care unit. Taking that same principle and now extending it out to wearables, right? We all know Apple Watch can kind of detect AFib or irregularities in your heart's rhythm. We've seen that with kind of, it's been more globally publicized, I would say. But imagine if you can take that same ECG or that rhythm and now look at what is the heart actually functioning like? You know, what is the ejection fraction like? What is the person's chance of getting heart failure? And then taking that a step further from that heart failure, what is the chance that, like, what class do they fall under? What is the chance, like, that they're going to deteriorate in the next few years? So the possible applications here are huge, from simple wearables as well. Generating medications. I could have chosen a better title. Like, I didn't mean like just literally generate them, like ChatGPT or something. But this is a huge area of research, and typically, if in drug development, things take a long time, right? For good reason. I mean, you have to make sure that drugs are effective, but that they're safe. Obviously, go through all the various steps, clinical trials. But now we have, since, for example, AlphaFold and being able to use AI to really map out protein structure, you have the ability now to accelerate drug development and target conditions that previously seem untargetable, right? For example, right, a new antibiotic, right? There's this deadly hospital superbug. So superbugs are bugs that don't respond to any antibiotic at all. And you're able to use a deep learning tool to invent an antibiotic that can then kill this deadly hospital bug. Idiopathic pulmonary fibrosis, right? 30 months to go from design to human phase 1. That's incredible, right? And it's already progressed through and showing promise. So a previously uncurable or unsolvable disease, what is that going to look like in the future? Creating novel proteins. So this is kind of very interesting, because imagine if the AI can now use protein folding in a way where you can generate new desired functions, new biomolecules with different desired functions. Again, you can create very targeted approaches, so like individualized treatment for a single person, as opposed to like one drug for a condition. You could have one drug for a patient that would be specific to that. So I referenced this earlier with my little joke, maybe the AI can go to medical school and become a doctor. Well, it already has, because if you look at MedGemini right now and the diagnostic capability of one, it scores in the 90th percentile of let's say, the US Amii, which is, that's kind of a great result. And so, we're getting there. We're getting to the point where AI is extremely capable. I mean, more than extremely capable at diagnoses. I remember an anecdote I read online. I can't remember exactly who or where there was a patient who had gone to like doctors for years, couldn't find an answer, and then he went to ChatGPT, and he put his medical history and years of symptoms, and said, find the zebras, find the rare diagnoses that this could be. And it nailed it. And, he had a diagnosis and his life probably changed. So diagnostics, I think, across, this is Google, but across all the different LLMs, I think we're getting there. Radiology. So this always interested me in medical school. Everyone would say, don't go into radiology. All your jobs are going to be gone. AI is going to do it all. And so now we actually have the emergence of these large language models that can actually somewhat, not 100%, but reliably kind of report on images, right? So over here, you can kind of see the sequence, and it follows kind of a different pattern. So you have a bunch of different, whether these are tools or models, or I'm not entirely sure, but essentially from that, you get a response and a diagnosis on the image. And just to kind of show you that, I'm not just like saying this. This was a study that was done for pancreatic cancers. And so oftentimes, CT scans, while they're great, they're not perfect, right? Diagnoses will be missed. Radiologists will miss, maybe smaller cancers or ones that are not as visible. So the sensitivity of the test or the specificity with a human is not perfect. It's good. It's what we use now. But what these guys here used, I think this was a company, what was it, in China, but yeah, Panda. And they actually created a tool that can reliably use AI to detect pancreatic ductal adenocarcinoma on CT scans with above 90% sensitivity and specificity, which is massive. And so if you take this one application, sure, it's just pancreatic ductal cancer, but if they can do that with this, why can't they do it for other modalities? Maybe now there's some technical limitations, but yeah. This, again, I'm wading into the ethics of this. So genomics and personalized medicine. I kind of alluded to this earlier, but you can tailor medication, you can tailor drugs to a person, right? Based on various factors, based on their family history, based on their genetics. And so that's something there. This one was kind of cool too. So it kind of is very similar to the Neuralink one. But this one was a bit different. So it gave this woman her voice back. And
today is an opportunity for Anne and Bill to have a conversation through our brain decoding to facilitate what we think would resemble a future use of an actual real-life application of the technology.
We want to try to basically create a demonstration where we're decoding the text, the speech, and the avatar at the same time from Anne's brain as she tries to silently attempt to speak. We just trained some new models yesterday, so we might need to test it a little bit.
Okay.
Because
yeah,
we'll run through some practice runs.
The device is an electrocorticography grid, which is attached to a pedestal, which is screwed onto the participant's skull. Anne is the very first person to have this combination.
I think you are wonderful.
In the training lab, we really focus on restoring voice to people that have lost it due to conditions like stroke or ALS.
What we're picking up on are neural activity related directly to the attempts to move her facial muscles, and that's what we're able to decode into speech.
Hey Anne, how's it going?
It is good to see you.
Giving them the ability to communicate again with their loved ones and caregivers is really what we're looking to do.
I was thinking about running to the store.
What time will you be home?
In about an hour.
Do not make me laugh.
That's the first time we've ever had a conversation using this system.
In order to communicate in her day-to-day life, she has an assistive communication device. These are dollar store glasses, and she interfaces with it using a little reflective sticker on them. It's very slow, and the device now is very old, but she relies on it.
For us to have that conversation using her Dynavox would probably be like a 5 to 7 minute conversation.
It was nice to have a conversation. I forget how slow this machine is.
When Anne was 30 years old, she was playing volleyball with some friends and had a stroke, which led to the condition that she has now, which is locked-in syndrome. So at this point, she had a 6-month-old child and a 7-year-old child.
You are truly wonderful people.
The physicians have no idea why this happened. That was now 18 years ago.
Hand that to me, please.
How can we create technology that can help people really meaningfully contribute with all sorts of abilities?
Hi, how are things going?
Hi Anne, things are going fine. How are you feeling about the Blue Jays today?
Anything is possible.
Oh, you're showing not a lot of confidence in that today, are you?
You are right about that.
I guess we'll see, won't we?
I feel really lucky to work with a group of students and fellows and engineers and scientists, all as a team that have had this singular goal for the last 10 years to build a device that can restore speech. And we are getting so close to making this something that is going to be a real solution for patients.
Will you do me a favor?
It's incredible to hear her discuss her journey.
Hand that to me, please.
Apart from her motivations to actually advance this technology,
I thought it would be good for me.
if you're able to produce text, synthesize speech, and then also a personalized avatar, she believes that would really, and we do too, advance her ability to become a counselor and to work with people. It's important to develop technologies which can better support individuals with disabilities, because it's a huge amount of people who we exclude from workplaces.
My hope is that this is going to be just a stepping stone to many other things that can be done for people who have lost the ability to communicate, to realize their full potential.
So again, another kind of example of using that brain implant or something similar anyways, to really improve someone's quality of life. Oops. Where do I go back? Okay, perfect. Yeah, so with this too, it's not like they were using like top grade text-to-speech or an avatar that could be generated like it can be today. You could take that and you can actually, turn it into her, literally, and have her speak in her voice and her intonation, with her tone and her sense of humor coming through like she would want it to, with her own avatar. And so that's possible today, but it's incredible. Obviously, kind of the last thing I wanted to talk about here is regulation, ethics, and bias, right? And always with AI, I think first I'll address bias. Any system that's created, there's going to be a degree of bias. We've seen that with ChatGPT. We've seen that more humorously, or maybe not so humorously, with Grok lately, which is Elon Musk's AI. So I don't know if you guys saw this, but it seemed like every time anyone would ask any question at all to Grok, completely irrelevant, it would respond with some message about the South African genocide of white people. So I don't know how that made it in there, but obviously there's some bias there. Ethics, obviously. So just as an aside, again, everything I kind of showcased here, it's more from a tech perspective, more from what's actually feasible and possible. In terms of the ethics, when you start to get into things like, analyzing someone's like genetics or creating personalized treatments, where does that kind of end and how does that snowball? We've all seen kind of those old kind of movies where, with kind of people wanting to create like perfect babies or have these like applications that realistically are very unethical, or just there's a conversation there at least. And then regulation, right? And I want to end with this, but at the beginning, I said there's good regulation and then there's maybe not so good regulation. I don't want to say bad because, everyone's trying to achieve an aim there. But what we need to do is foster an environment that allows us to innovate and allows people to develop tools like the Neuralink, like the speech implant, like things that can solve data interoperability. I think so far, we kind of have a good balance going. But the fear I have, and I think this is going to hit people really hard, really soon, is when this exponential curve takes off, our laws and our regulation are just archaic and ancient, and it's just not going to keep up. And at this point, I don't know what people are going to do. I'm not like a politician or a lawyer, but yeah, it's not enough. Like at this point, sooner or later, just like when the internet first came out, and I mean even till today, it's exploited for many bad reasons. I think we're going to see that on a whole different scale when it comes to AI in the future. So yeah, it's a whole new world. So that's kind of the talk. Questions, my AI will not answer them. I just put that in there, but. Yeah, happy to answer any questions.
Hi.
Hey.
Thank you so much for presentation. It's extremely incredible how AI may change some healthcare work. I have one question about your Scribeberry.
Yeah.
Things. Sorry if I butchered the name.
That was good.
I face that LLM always hallucinated, and when you convert one form to another, it may provide you new symptoms or write some different some subscription. How your program can mitigate it? Which way you find to decrease the risk?
So there's kind of two aspects to this, I guess. Like first is specific to our program, and then I think like broader implications. So with our program, I mean, we have a lot of different ways that we do that. First is kind of how we actually, obviously, like just superficially, like prompt the LLM, right? And how you instruct it. That's going to make a huge difference. Second is how you augment or kind of train the data that it's using, right? And how you clean it up or curate it in a way where those hallucinations don't happen as much. The third, again, like maybe more like with that RAG and kind of training, but maybe at a bit of a deeper level. And then the fourth is obviously keeping the human in the loop, right? And so not pushing it right away, into like a record or into something that has severe consequences, but actually keeping that human in the loop at the end. And so we've got to a point where, most of the notes are, if there's any edits, pretty minor. So that's one thing. And then I think the second is like on a broader scale, we have to remember like these tools are going to accelerate, right? And so now we have hallucinations, we have, all of these things. LLMs sometimes get stuck on problems, that children could solve, like how many letters, how many R's does the word strawberry have, for example? Like it struggles with that, but then it'll answer PhD questions. So, yeah. So I think time will help as well on a broader scale. Yeah.
Thanks so much.
Hi. First off, great session. So informative. I work at the University of Alberta, and I support the teams that recruit and advise for the College of Health Sciences. So I'm curious as to what would you have as messaging for prospective students looking to enter health sciences field if they have questions or curiosities about these intersections and maybe what their future would look like as they enter health sciences, and what they can maybe expect, and some messaging that you would give to prospective students.
These would be like undergrad or postgrad?
Both.
Both, yeah. Honestly, like I think like education at the end of the day is like very fundamental, no matter what field you're in, because it just kind of gives you the ability and tools to have that curiosity to explore different areas, right? And that starts from a young age. When kids learn to read, they can learn so much more about the world. And so I guess like I would just say, go into it with the interest of like wanting to learn and wanting to discover things. I know it sounds really cliche, but I wouldn't let like the concept of AI detract you or scare you or, make you fearful. I would kind of embrace it and say, well, obviously things are going to change rapidly, and it would be like an exciting opportunity to be in that field when that happens. So, I don't know if that answered it, but yeah. Yeah, no problem. Awesome. Thank you, guys. If anyone else has any questions, I can hang around too, but I appreciate it. Thank you.